online? I'm sorry, that's just not the. You're ready?
Okay, let's go ahead and get started. Thank you all for coming. And I'd like to call the meeting to order. And we'll go ahead and start with a few basic housekeeping instructions, since this is a venue that we haven't performed this meeting at previously. And so we have people that are here both in person and also participants online. There will be time allocated in the meeting for public comment. If you're attending the meeting via your phone, then what we ask is that if you'd like to raise your hand to speak, you can hit *9 on your keypad. If you're attending the meeting via computer, Zoom, or on an iPad, then you can go to the Participants tab and hit the Raise Hand function at the bottom of the screen, and then we'll recognize you and let you know when it's your turn to speak. What we'll do in periods for public comment is we'll start with folks that are here in person for public comment, recognize them. Again, public comment 2 minutes, and then we'll move on to anyone online and attending virtually. Okay. So we'll go ahead and start with introductions. I'm Dr. Burley. I'm the EMS Medical Director for Monterey County.
Teresa Rios, EMS Director.
Scott Houchin, First Responders.
Steve Brooks, EMS Agency Staff.
Do we have online?
Good morning, this is Jeff Horner, Program Director with CalSTAR.
Dave Craddock, representing fire-based paramedics.
Michelle Kolinsky-Chaw.
Cassie Caldera Natividad.
Tina Nieto, representing law enforcement.
William Heller and AMR.
And Ben Hitchcock with AMR.
Is that everyone, April? Okay, perfect. While we're working on that, let's take a moment to review the past MAC meeting minutes, and we'll look to approve them.
Motion to approve.
Okay, thank you, Scott. Do we have a second?
Jeff Horner, I'll second.
Okay, thank you. All those in favor of approving the minutes? Aye.
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 Are there any opposed? Okay, great. The meeting minutes from the past MAC meeting have been approved, which moves us on to EMS recognition. We don't have a specific individual to discuss, but I just wanted to once again express our gratitude to the providers, police, fire, EMS, hospital personnel who are on the front line during this very difficult time, and express our thanks as an agency and as a community for the excellent work and heroic practices that everyone is doing to keep our residents safe. So thank you so much. There's no correspondence on the agenda, which moves us to old business. Under EMS agency COVID-19 response.
Thank you, Chair. Attached in your packet is a staff report prepared by Troy Mead, who is not here today. He was not feeling very well. It highlights some of our activities, some conflicts that we're having achieved during this period.
Thank you. And this moves us on to EMT scope of practice. Steve, you have something for us?
So related to the scope of practice, you'll find a staff report within your MAC packet. The reason we're bringing this forward is at the last MAC meeting, this committee endorsed the use of epinephrine autoinjector and naloxone for use by EMTs and EMR, and we said we'd come back with an effective date. So we are pushing this forward for an effective date of January 1, 2021. At this point, what we're doing is letting folks in the EMS system know so that they can prepare budget and be able to acquire the appropriate equipment and do the training. The EMS agency will put out some training materials, and we'll have it to the agencies by the end of August, so that there will be adequate time to do the training necessary to put these policies and protocols into practice. Of course, along with this, there are also several other policies and protocols that will need to be updated, and we'll be bringing those forward under new business for endorsement by this committee.
And that covers the epi autoinjector as well as naloxone.
That is correct.
Any comments, questions? Okay. Which moves us on to new business, and we'll start with MAC membership, reappointment of those with expiring terms. Steve?
Oh, excellent. Thank you. Sorry. I'm still putting these last ones together. All right. So, again, there's a staff report in the MAC packet related to MAC membership reappointments. And so to be consistent with EMS policy 1020, EMS Advisory Committees, membership in MAC is a 2-year term. Half the membership expires each year. So the following members have their term expiring July 1st, 2020. We have considered that unless these members request to not be on MAC, we'll consider an affirmative request to assent to reappointment. The members being reappointed are Jeremy Hadland, representing Base Hospital Coordinator at Salinas Valley Memorial Hospital, Greta Steinbrunner, paramedic representing the ambulance contractor field staff, David Craddock, paramedic representing the paramedic field staff other than the ambulance contractor, Scott Houchin, representing first responder personnel, Will Hiller, representing the ambulance contractor AMR, Jeff Horner, representing air ambulance providers, and Tina Nieto, representing law enforcement agencies. So we will assume that you've provided assent. If you wish to step down from MAC, please let us know, and we appreciate your continued service.
Thank you, Steve. Let's move on to EMCC. Oh, are there, April, are there any questions from the? No, okay, just let me know if any come up. Which moves us on to EMCC, Emergency Department Physician Member Nomination.
Thank you, Chair. Dr. Sean McRoberts has decided to step down from the EMCC as the emergency room physician representative in that committee. The emergency room physician must be nominated by this committee, and we bring forward two individuals. Dr. Noah Hawthorne from Me Memorial is being nominated to take Dr. McRoberts' place. And we also received have a nomination for Dr. Greenson from SDMH to become the alternate in that committee. So we look for an endorsement. We look for an endorsement from this committee.
Okay. So do we need
A motion.
a motion? Okay.
Before the motion is made, I'd like to just thank Dr. McRoberts for his commitment to the EMCC and the years that he has provided great contribution to our system through his representation on the EMCC.
Absolutely.
Can I ask a few?
Go ahead.
Can I ask a few questions here? So, how did I end up becoming the alternate?
Well, we are.
I'm just curious. I thought I applied for the, membership or whatever.
Yes. What we do when we review the nominations is that we look for the representation on the committee, and one of the things that was lacking is representation from South County, from Me Memorial.
Okay.
So that is the only reason why. But
Okay.
So you also provide enormous contribution in this committee.
Well, thank you. I really appreciate that. But question number two is it just strikes me. I mean, are they planning on having someone attend the MAC meeting? Because they just historically, I mean, they're invited to this, right?
We're working on the recruitment for any vacancies we have in any of our committees.
Well, okay.
And we're trying to have a well-rounded representation on our committee. So Steve is actually started to work on looking at the vacancies that we have in MAC, and we'll start reaching out to fill those vacancies. Okay,
because I don't know. I mean, my just humble opinion here would be that the place to start with that would be MAC, and make sure you're actually going to have someone, attend and be present and stuff like that, since they've been invited and historically haven't attended. From a physician standpoint, and then EMCC after that. I don't know if someone else thinks that's reasonable, but I just, I would be worried since they've been invited to MAC and haven't historically shown up in the decade I've been here.
If this is Michelle Kolinsky, if I can have a moment, I actually take a little opposition to utilizing this position to represent South County. This is not a representative of South County on EMCC. This is a representative of the emergency physicians. And I would have to concur and agree that I was a little surprised that we chose a physician that was a non-base hospital facility, because I think that while they do interact with the EMS, The view of a base hospital physician is very different in terms of its interactions and direct control with paramedics. And I would prefer to see a base hospital physician represent the ED physicians of the county in this position, rather than representing a geographic area. I do agree that South County needs to become actively involved in EMS. I've actually been a little surprised that they haven't had better representation. They're a huge growing part of the community with a unique, diverse area that really needs better resource understanding, and they are the ones that can provide that. I'm not certain that having a South County ED representative is a good representative for the base hospital physicians in the community. And I would concur, I have slight concerns with this. I know when Dr. McRoberts stepped down, he asked for approval, and we felt that one of the other base hospitals should be represented since Chomp had held the position over the last few years. And I would concur that perhaps choosing an NMC or SVMH representative and allowing South County a voice at other areas in EMS would be beneficial. Thanks for the time.
The committee can change, can do as it pleases. The committee can do as it pleases. Nominate, if they want to change the nomination, they can. They just need a motion.
Yeah. So what we're looking at is if we'd like to change the nomination, we can do that. We just would need a motion to make that change.
I would motion then to alter it to a base hospital physician. I think Nick was the only other applicant. So Nick to be primary and let me take the secondary as the South County representative. And please encourage them and allow them a spot in the other committees, because I do think them having a huge active role is going to be imperative to a quality EMS system in the county.
Okay, so we have a motion. We have a second.
Yeah, this is Jeff Warner. The comments made by Dr. Greenson and Dr. Kolensky, and I would second that motion.
Okay, we have a motion and a second, and we'll go ahead and take a vote on it. All in favor?
Aye.
Any opposed?
Aye.
Wait, there was some opposition?
Those were late ayes.
Oh, okay.
Okay, so looks like the motion carries. So welcome to Dr. Greenson, and we will move on then, unless there is any further discussion. We'll move on to airway management policy.
Again, good morning, Steve Brooks, EMS agency staff, speaking to this. The EMS agency and Dr. Burley, as the medical director, have been looking at the use of supraglottic airways and looking for the best one to use within our system, especially as we are considering having a provider be a EMT expanded scope provider and being able to use supraglottic airways. There was a review within the agency of the various airways, specifically the LMA, the King tube, which is currently in use, as well as the iGel. And a review of the literature finds that the iGel seems to be reported to be easier to use by those who have used it and been trained in it. They have more confidence in it, and the literature seems to show that the results are about the same. We've looked at the cost. We found that the cost for an iGel seems to be lower, and so we are proposing moving the supraglottic airway approved for use in Monterey County from the King tube to the iGel. We also recognize that there is a financial commitment by our paramedic providers to have King tubes stocked and available. So in an effort to mitigate some of the expense of the transition, the iGels will be approved for use effective January 1, with phase out of the King tubes over 6 months, so that effective July.
For this topic? Well, let's wait, let Steve finish. Go.
So we'll have the iGel be the approved and supraglottic airway effective July 1. So that will give a 6-month transition, and of course, almost 6 months now to start ramping up for that. At this point, are there any questions? We'll also be, before I forget, we'll also be bringing forward various policies and protocols that will need to be updated for this.
Thank you, Steve. Are there any questions from attendees? Okay.
This is Michelle Kalinsky. I have a question, if I could. Since we're moving to a airway that has, I guess, broader availability and applicability, will it be utilized in younger age groups?
Yes, so we're looking at ALS providers being able to have on stock pediatric size iGels. And so in answer to your question, yes, we're looking at younger age groups as well as adults.
Excellent. So there'll be new protocols coming forward to address the appropriate use in this age group, and
Correct.
Those are under development? Okay.
To, if I may,
Yes.
to also answer that question, we are really looking for the adult use for both ALS and EMT expanded scope, and limiting the pediatric iGels to paramedic providers. And we'll see that as we go through the policies.
Any additional comments or questions? Okay. So we'll move on to allergic reaction and anaphylaxis protocol revision.
Before we do, I think we would like a motion to have endorsement to move this forward from the committee. That way we get buy-in, and if anybody has objections, then at least they have an opportunity to raise them at this point.
Okay. Yes. We have two. Go ahead with the first one. Okay.
Hi.
We have a comment from David.
Sorry about that. Can you hear me now?
Yes.
Okay. I just wanted to make a motion to proceed with the iGel and the associated protocols. That was my only comment there.
Okay. Thank you. And do we have another comment?
Second.
Do we have any more comments on there, or are we ready for a second?
I'll just provide a little bit more info if I could.
Okay.
So, Steve Brooks, EMS Agency, again, a little more information just to run through the policies and protocols that are attached related to this. You will notice on the airway management policy 4502 that it does add EMT expanded scope, may use them, and it changes King airway to supraglottic airway to be a little more generic. And let's see, it will update the scope of practice for ALS, EMT expanded scope, as well as policies 4110, 4120, which is authorized stock for ALS and BLS. So we'd be looking for endorsement to change the airway, supraglottic airway related issues in those policies as part of this motion, if that's all right with Dave and Scott.
So we have.
Yeah,
we
that was
have a
actually my
motion.
intent.
I'm sorry. Go ahead. Say that again.
Sorry about that. I was just responding to Steve that was my intent, but I had the opportunity to go through all of them before now. So I appreciate him going through that so that everybody kind of knows.
Perfect. Thank you. So we have a motion on the floor. Do we have a second?
Second from Houchin.
Scott. Okay. So we have a second, and so all in favor?
Aye.
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 Any opposed? Okay. Thank you. So the motion carries, and that will move us on to allergic reaction and anaphylaxis protocol revision.
So this again, a lot of these protocols and policies that we're bringing forward are related to things we've discussed. So this is allergic reaction anaphylaxis, adult patient, protocol E2, and we are allowing EMT and AMR, emergency medical responder, to use epinephrine autoinjector and specifying the dosage for this. For the adult patient, we will be bringing protocol EP2, allergic reaction anaphylaxis, pediatric, basically the same thing. We have epinephrine dosing as well as use by EMT and EMR for that. The overdose and poisoning protocol, which is to update EMR for naloxone, and as well as the overdose and poisoning pediatric to update naloxone for EMR. It basically just removes the note that says EMT only. Then we have the, again, the EMT scope of practice, which, as we've talked about, it changes to adult supraglottic airway for the EMT expanded scope. And that's what I have at this point. Looking for a motion and move that forward.
Okay. We have a comment? Yes. Go ahead.
Hey, it's Cole here. I just had one quick question. Under the pediatric allergic reaction protocol for the EMT scope of practice, it says to use the epinephrine auto-injector for at the 0.15 milligram dose. Below it, it does specify doses that are weight-based for epinephrine. But I was just wondering if maybe in there we should just include a weight range for the pediatric dose as opposed to the adult dose, because I think greater than 30 kilograms, we give the adult dose of 0.3 milligrams. If that's just specified under the EMT's part of the program or part of the policy.
So your comment is to include a weight-based dosing for the pediatric epinephrine?
Yeah, just for the EMT, because in the EMT it says to use the auto injector, and it just says pediatric on there. So maybe under that, just to say for up to 30 kilograms, for auto inject zero at the pediatric dose, and for greater than 30 kilograms to give the 0.3 milligram auto injector.
Right, using 30 kilograms as the cutoff between adult and pediatric dosing, regardless of age, essentially.
Yeah, if it's for the EMTs, I mean, if you're calculating out what you're going to give, it's different. But if basically just having the weight in there so that the EMS provider doesn't need to necessarily calculate out the dose, just so it's specified.
Yeah. Any comments on that?
This is Michelle Klinsky. I would agree with Cole on that. And then the other thing I would say is your minimum stock needs to be updated to reflect that they have to carry both auto injectors then, because right now it doesn't specify the number or, you know, the fact that there's two different dosing. It just lists epi auto injector.
Okay, thank you. Any additional comment?
From a stocking standpoint, would it be easier just to stock the 0.15 milligram auto injectors and just say for more than 30 kilograms to give two? Or are the prices, I don't know what the price difference is between them.
We can look into that and come up with whichever seems to be most feasible.
Okay, because then you only have to stock one item. I mean, you have to stock twice as many. So if they're twice as expensive, it maybe doesn't make sense. But that way you only have to stock one item.
Of course, then you give two injections, but yeah. George, you had a comment? Okay, so the comment was in pricing, two auto injector pricing started at $600. Yeah.
If I may, Steve, EMS agency staff, to remind the committee and members that AMR has offered the pricing that they can get, and they specified price of about $59 for the epinephrine auto-injectors, as long as they were able to purchase 30 of them, which we would expect our BLS providers to get together to purchase together a total of at least 30.
Yes? Thumbs up from George. Okay, great. So I think the 30 kilogram caveat is a very reasonable suggestion, and so we'll incorporate that. And so we're looking for a motion to move forward with these protocol revisions.
Motion to move forward.
Thank you, Scott. We have a motion on the floor. Do we have a second?
Second.
Okay, thank you.
May I get who that second was?
Greta Steinbrenner, paramedics.
Oh,
Thank you, Greta.
no problem. Thank you, Greta. So we have a motion and a second, and let's go ahead and take it to a vote. All in favor?
Aye.
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 Any opposed? Okay, thank you. The motion carries. We'll move forward with those protocol or policy and protocol revisions. The next item on the agenda is major trauma patient policy revision.
So we are updating the major trauma patient protocol. There was a working draft that was included, so if you're looking in your packet, please pass up the first one and go to the second one. A couple of changes that we've added to this. We are referencing a new policy called hemorrhage control in the major trauma patient, and that'll be discussed after this. We have clarified that the injury-specific trauma care is ALS and BLS, and then the major revision on this is down toward the very end under crush injuries. This was brought up at the last MAC meeting. I believe Dave Craddock brought it up. We looked it up, and we have updated the protocol to be in compliance with PHTLS. So we have moved, we've said do not use lactated ringers since people are carrying it now because it contains potassium. We've also moved calcium chloride to the start of, that's your number one drug if you're giving, and we've said to make sure that all meds are given prior to releasing the patient from the crush injury, from the whatever's crushing them. This protocol was sent out to TQIC, and a couple of revisions have been made based on their input. I'll go on to the hemorrhage control protocol. Again, a working draft was put in there, so please go to the second one. We have BLS care, and it is basically stop the bleed, direct pressure, pack the wound with hemostatic dressings, and a tourniquet for extremity bleeding. ALS care is TXA. We've discussed this at the last MAC and at TQIC, and we got the go-ahead to look at this. We have a training set up for it. This is not standard scope in California. It is local optional scope of practice. I've submitted the paperwork to the state to get this approved and confirmed with them that the protocol does not have to be absolutely complete in order for them to approve it. Basically, TXA is mixed in 100 cc's of normal saline, given over 10 minutes. The injury or bleeding must not have started any longer than 3 hours prior to giving the TXA. And we are approving it for significant hemorrhage, estimated blood loss of 500 milliliters with a heart rate of greater than 120, hemorrhage not controlled by direct pressure, hemostatic agents, or commercial tourniquet applications. So this opens it up beyond trauma to significant vaginal bleeding or significant GI bleeding. Again, it has to have been within 3 hours to give this. It can create harm beyond that. And we would be looking for approval on both or endorsement from this committee on both of these protocols.
Okay. Go ahead with your question from the panelists.
It's Michelle Kalinsky. So there's a recent trial with use of this medication in GI hemorrhage that did not show favorable outcomes. I have concerns with expanding it into this scope until these areas are more clearly delineated. GI hemorrhage sometimes is difficult to determine onset versus trauma, and I think that this would probably be a, how should we say, less than desirable kind of use of this medication in an EMS setting at this time.
Go ahead. Yes. Go ahead, Cole.
Sorry about that. I was trying to get it unmuted, figure out how to speak here. I think, do we know how many patients from a non-trauma standpoint that we transport would be even candidates, like for this, say, potential GI bleeds or vaginal bleeds or other, I guess, maybe major epistaxis or something like that that would even qualify for this?
I don't have that number. I did check with Julie Ramirez at Natividad before writing this to find out how many times the massive red blood replacement protocol was utilized at Natividad. It was used 29 times last year. So I am based on that in my local optional scope of practice application to the state. I had said maybe 2 to 3 times a month that we would anticipate this to be used.
Because I think if it's, I mean, I guess we could always just have it say for blunt polytrauma patients or with suspected massive hemorrhage, or just to make base contact first. I mean, if it's not a super long transport time, then it probably isn't that big of a deal if it's a questionable indication to begin with.
Yeah, I think that's reasonable.
I think halt it really needs to be reviewed before we put this on there for GI bleed. You know, vaginal bleeding is external, visible. You can tell the hemorrhage, it knows onset. GI bleed, halt it sort of really made it so TXA is not a great option at this point. And I think we should just remove that as an indication, keep it for obvious things that it's known to be beneficial, trauma less than 3 hours, and vaginal hemorrhage acute onset.
I think that's reasonable.
This is Will Miller from AMR. I agree with Dr. Kalinsky completely. It would be almost impossible for us in the field to determine the onset of that GI bleed. And I just basically agree completely with Dr. Kalinsky. And I also had a question: would this be required stock for both the ambulance and fire departments?
I'm sorry, I wasn't able to understand that.
So you're a little broken up. Are you still there?
Will, was that you?
That's Will, right, April? William. Yeah.
Go.
I'm sorry, this is Will Heller. Can you hear me now?
Yes.
Yeah.
Sorry. I was just saying I agree with Dr. Kalinsky completely and Dr. Click that it would be difficult for us in the field to determine the onset of these GI bleeds. So I'd like for it to be revisited for that reason. And I'm also curious, is this minimum stock required for both the ALS ambulance provider and the fire departments?
We updated the stock policy to where transport providers would carry 2 vials of TXA and 200 cc's of normal saline, and non-transports would carry 1.
Any additional comments or questions? So
what about just moving forward with trauma, and then I guess that's kind of what the other people are saying, but just moving forward with trauma and the potentially vaginal bleeds.
Yeah, I mean, it sounds like the suggestion is to take GI bleeds off of the clinical indications for the time being until we have additional data, and but keep vaginal bleeding and epistaxis on the medical indications.
I have one question about the epistaxis utilization. I mean, usually it's used topically. So will it be used as a topical, or are you going to be giving injectable?
No, this would be an injectable.
Okay. I don't know. That's one that's almost, I guess if it's 500 mLs from a nosebleed, I suppose that's okay, but just not usually how we most commonly give it. With regards to GI bleed, I mean, HALTED is a huge trial that's well validated. So I would say just remove it. And if something comes up where we're able to time things and find true benefit, great. But at this point, I think the standard needs to be that it's not utilized in the GI bleed setting. Vaginal bleeding is fine, it's validated and evidence-based, and keeps this very evidence-based. You're expanding into an optional practice in local EMS. It's evidence-based for trauma less than 3 hours in these indications. These others are highly controversial right now and not well studied or validated. And I think, you know, this new trial pretty much puts a halt on any GI bleed use until we sort things through.
Okay. Thank you, Michelle. So we'll go ahead and see if we can get a motion to move forward on the major trauma patient policy revision and hemorrhage control policy revisions, with the caveat of removing GI bleed from the clinical indication for medical administration.
This is Jeff Horney. I have a question, actually. Laura, I apologize because I don't have your latest revision in front of me for review. And maybe I missed it, but is for inclusionary criteria for trauma, is there a parameter for blood pressure, and is there an age cutoff for pediatrics? I think, you know, just basing it on heart rate greater than 120 and then an estimated blood loss of 500, we all know how erroneous the estimated blood loss is in the field especially. So I was curious if there was a blood pressure parameter and age for pediatrics.
I'm sorry, you got a bit muffled there. I think you're asking about estimated blood loss greater than 500 with a heart rate greater than 120. Is that correct?
I think his
Yeah,
question was whether there's a blood pressure parameter within the protocol for administration.
No, because blood pressure is such a late sign of shock.
I think we did discuss that clinically and felt that waiting for hypotension may be unnecessarily delaying administration when patients are in early stages of shock, and so we decided not to include blood pressure, but to include heart rate. But we're certainly open to discussion on that issue.
Okay, yeah, I just wanted to bring it up and appreciate the consideration. We're just like reviewing our internal protocol. And then my second part of the question was, is there a age cutoff as far as any consideration for the pre-hospital provider?
15 years old is what's in the protocol, less than 15. Meaning less than 15 is excluded.
So exclusions for patients less than 15 years of age.
Okay. And is there an exclusionary criteria for isolated traumatic brain injury?
Yes. Yeah, I can go through it. The exclusion criteria in the protocol: less than 15 years old, time since injury greater than 3 hours, isolated traumatic brain injury, thromboembolic event in the past 24 hours, such as stroke, MI, or PE, traumatic arrest with greater than 5 minutes of CPR without ROSC, or hypotension secondary to suspected cervical cord injury with motor deficit or spinal shock.
Great, thank you, Laura, and I apologize for taking the time in the committee and not having the latest revision in front of me.
Yeah, no problem.
Thank you, Laura. So do we have a motion to move forward on the policy revisions?
Motion to move forward.
May I ask who that was?
Cole, click.
Thank you.
Do we have a second?
I'll second it. This is Will Hill.
And sorry, when we get motions and seconds from folks who are joining us virtually, can you just say your name so we can use that for the record?
I second it. This is Will Hiller.
Okay, thank you, Will.
Thank you, sir.
Okay, great. Thanks so much, and good discussion on these policy revisions. Pardon me? Oh, yes, I'm sorry. So all those in favor of moving forward with the policy revisions for major trauma, patient policy, and hemorrhage control policy?
Aye.
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 And thank you. And any opposed? Motion carries. Which brings us on to authorized stock, BLS and ALS.
Steve Brooks, EMS agency staff. Bringing this forward at this time, it's primarily related to the things we've previously discussed, but just to make sure we walk this through, we've, on the paramedic provider stock, deleted King Airway and added the eye gels, and we've added normal saline, IV 100 milliliter size. We will look at the pediatric epi auto-injector based on discussion today. We've added TXA. As we've made a correction also in the policy, we neglected to add hemostatic dressing before. It's in the BLS authorized stock, but not on the ALS, and that was simply an oversight, so just let folks know that that's also being proposed, as well as chest seals were added to the BLS stock, but not the ALS stock, so we are attempting to correct that. I would like endorsement to do that. On the authorized stock BLS units, the changes are, probably will I get to it, really just the naloxone and epinephrine auto-injector, adding those.
All right, thank you, Steve. Any discussion? Okay. Do we have a motion to move forward on policy revision regarding authorized stock for ALS and BLS? We need a motion to move forward on authorized stock revisions.
Michelle Kalinsky, I'll motion.
Thank you. And a second?
This is Will Heller. I'll second that.
I think I got Scott first, so thank you, Scott. All those in favor of moving forward on ALS and BLS stock revision protocols?
Aye.
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 And any opposed? Thank you. Motion carries, which brings us on to paramedic scope of practice policy revision.
Steve Brooks, EMS agency staff. The policy is being revised for two items. One is TXA, as well as a correction on terminology, which we're really not asking for, on IV cannula, and to add supraglottic airway to exchange for King tube. So it's a housekeeping mostly, but would like, again, endorsement, just making sure we're moving on the right track.
Okay. We have a motion for paramedic scope of practice policy revision.
Michelle Kalinsky, I'll motion.
Thank you, Michelle. We have a second?
Second.
Thank you.
Greta.
Greta. Very good. And all those in favor?
Aye.
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 Any opposed? Okay, motion carries. Thank you. And then the last item under new business is 2020-2021 policy development cycle staff report.
Steve Brooks, EMS agency staff again. It's time to look at our policy and protocol revision cycle. And one of the things we're doing is try to start a little earlier this cycle so that we can give a little more time for the public comment period that won't necessarily go over the Christmas holiday period. And that also gives EMS agency staff some time at the back end to take into account the excellent suggestions that are usually made during the public comment period, so that we can adjust the policy drafts and move them forward. So you will find in your packet a staff report related to the policy cycle, and we're bringing several policies forward for revision, as well as just some new policies that we will be looking to bring forward. And at this point, I don't want to necessarily read through them all, but you'll notice that in the staff report, there's policies that are for revision, as well as new policies, protocols for revision. It's much less than there have been in previous years. You'll also find a section for policies for review, as well as protocols for review. If you look at those policies, these are policies and protocols that have hit the review date either this year or in the past. And so these are ones that we're just going to look at, but if anybody has something that they would like to add to those, we'll certainly move them forward in the packet of policies and protocols that we'll be revising. So that's what this is. If there's any questions, suggestions, this is the time to help us get launched.
Thank you, Steve. Any comments? Okay. Thank you. So that moves us on to EMS System Quality Improvement Program, which we don't have any specific reports this cycle, which brings us to emergency communications drill reports for ReadyNet.
Steve Brooks, EMS agency staff again. Within the packet is the 800 megahertz medical radio test system testing results for the period of June 19 to May 20, and you'll see that in general we're getting it down. Still seems to be some issues with SVMH. I've just got this from Jared, who has recently left our staff, so I don't have a whole lot of detail behind it. But if there are questions, I'll see what I can do to either answer them or provide the information offline.
Any comments or questions? Okay. This brings us to any future agenda items.
Dr. Burley, can we maybe add to a future MAC meeting the topic of addressing preferred transport patients for hospice patients and whether they need to go to a specialty designated center?
So just to be clear, you'd like to add an item for the transportation of hospice patients and whether they go to a designated center as opposed to the emergency department? Is that what your question is?
Well, I emailed you guys previously. There's issues with the language and the policies for trauma and others that are attempting to divert these end-of-life care patients to high-level tertiary facilities. And so we just need to probably reword that language.
So rather than transporting to a tertiary facility, your proposal is to reword the language such that the patient would be transported to the closest appropriate facility.
Correct, as these are patients that are end-of-life care and not requesting intervention.
Okay. Great. Another question? Cole, go ahead, Cole.
Oh, I had lowered. I was wondering if you just meant basically people who are actually on hospice, and I think that's reasonable.
Yeah, I think that was the intent. Any further discussions regarding that? No. Okay. Well, we can add that as a future agenda item. Any other future agenda items that you'd like to add?
Dr. Burley, Jeff Warner here with CalSTAR.
Yes, go ahead.
Yeah, I'm not sure if it would be appropriate to present to this committee or not, however, or just to yourself directly, but we are interested in having the county apply to the state for the expanded unified scope of practice for flight paramedics. We have 15 counties throughout the state now that have opted in for this and applied and been approved for the county. And we have multiple other counties pending their application, including Santa Cruz County. And we've also engaged with Dr. Miller at Santa Clara County. So I'm happy to discuss offline with you, sir, if you'd like to care or discuss in greater detail, or I'll defer to you if this needs to be brought to this committee for review and approval.
Yeah, so let's start with offline discussion, and then we can go from there.
That'd be great. Thank you very much. I'll follow up with an email to you as well.
Okay, thank you. Any additional items? Okay, thank you. And that moves us on to announcements and go to the order. Do you have any announcements?
Thank you. The EMS agency, we wanted to report that we are experiencing some vacancies. As Steve just mentioned, Jared Bagwell, his last day was yesterday with the EMS agency. Also, Troy Mead will be leaving at the end of this month. We have already brought one EMS analyst as a temp, and on Monday we have a second one starting so that we can make sure that we have continuation of services. In the meantime, our recruitment is already out. We are hoping to complete the recruitment. I apologize, my hearing devices. To complete the recruitment of the EMS analyst probably by September, have the EMS analyst positions filled. And we're also moving quickly to fill the administrative services assistant position that has been vacant for quite some time.
Thank you, Teresa. Any additional announcements or items for good of the order? Steve?
Can I just real quick make a comment?
Yes.
So I'm still seeing nebulized albuterol given in the back of the ambulance for kind of questionable indications. They're stopping it before they get to our facility, but I just don't know if the risk benefit, if it's worth doing. Actually, I think it's probably really dangerous and probably shouldn't be done. But I was curious if that message needed to be reinforced. Thanks.
Thanks for your comment. As you're probably aware, we have issued recommendations to avoid nebulized treatments and CPAP, if possible. Of course, the provider's judgment comes into play, and we respect their judgment as far as whether they feel that the patient needs it as a life-saving measure, and we don't want to withhold it if they feel that that's necessary. But certainly, we've made that recommendation to minimize use of nebulized treatments if possible. Yes. Okay. Go ahead, David.
I just wanted to agree with Dr. Greenson and ask if you might be willing to reconsider just re-emphasizing that point, because I think that when the initial direction was given, it was fairly early in the pandemic. And I don't think people had as good of an understanding of how dangerous it actually is to administer nebulizers as we do now. And it might be beneficial to just kind of revisit that and re-emphasize it for some of the folks who maybe didn't have that understanding in the beginning.
Okay. Thank you for that. And is there another comment?
Yeah, it's Michelle Klinsky. I would agree with everything that's said, and I think continuous kind of education and reemphasis is important. One other question I have is there an option to allow a alternative scope to nebulization, such as the administration of epinephrine or an MDI with a spacer or something that would be less dangerous in the back of the rig? And could you maybe facilitate that as the director?
Thank you. It's something that we can discuss within the agency and see if there are some alternatives to nebulization. And we'll go ahead and redistribute our recommendations to just remind folks of the importance of minimizing nebulized and treatments and CPAP in the back of the unit. Any other items?
This is just to add on to the nebulized thing we just went through. Real quick, is there any way to get the medics filters to put on their ambu bags, and the same thing if they want to use nebulizer?
I'm sorry, this is Will Hiller from AMR. We definitely do have filters for our BVMs. We're looking to get the spacer rings for our CPAP machines to have a filter on those. The direction that we got from the county was, I would say, it was recommendations. It wasn't a new policy. We sent a direction out to our crews to either lessen the usage of those nebulizers or do it in a well-ventilated area prior to transport if possible. But in the end, the direction was to give you guys a heads up as soon as possible for you guys to make the decision whether or not you wanted any of those devices to be used on that patient. And I'm hoping that our crews are utilizing the base hospitals for that, for direction there as well.
So, Will, it's Michelle. I don't think that my crew has received any base physician calls for direction on the utilization of nebulized medications. We do have discussions with them about discontinuing upon arrival at our facility, but I really worry about medic safety in this, and I think we can do a better job of providing alternatives, and we probably need to let them understand that particularly in the COVID era, you're going to have abnormal breath sounds that you're not going to get rid of and you're not going to make better, no matter how many things you nebulize, no matter how many times you try. And really, it's just a matter of supportive care and getting them there alive, because you're not going to resolve these issues. And I think we can do better at providing resources, education, and a safer practice base.
I agree, and I think that direction, we should have specific direction from the county for that. And I would say that the crews are calling into your hospital and letting the nurses know what treatments are going on in the back of that ambulance. And if we're asked to stop, the direction is to get the doctor's name. So if they are being asked to stop, we will follow that direction always.
Yeah, so Will, I think from a base hospital perspective, when you ask nursing, the only thing we request is that you stop prior to entering our facility or your offload. But again, I'm speaking of this now from a broader perspective, not just a facility, and worried about medic safety in the back of the rig. And I think we can do better providing alternatives and education to understand. I mean, you guys want to fix stuff. You want it to sound better, but this is not going to sound better. So
no, I agree with you. I would just say that we have not had solid direction from the county as to that. It was very vague guidelines each time. So if we could get specific guidelines from the county, we're on it. And I agree with you. We have been educating and asking that nebulizers be used or not used, or if they're used, just quite scarcely. But again, we're not given specific direction from the county. It was consider, not don't use.
Right, well, and that's what I think both Nick and I are asking Dr. Burley for at this time, is to provide a more, I guess, broad-based alternative with clear recommendations so that you guys can provide this out in the field and we can keep everybody a lot safer, because this is going to be going on for a while.
I agree, and thank you for that.
Great, thank you so much, and we'll go ahead and issue some more specific recommendations and regarding treatment of these patients from the pre-hospital field, and also try to come up with alternatives to nebulization so that we can maintain medic safety. Do we have any additional comments? Okay. Thank you so much. The next meeting is on September 9th, currently scheduled to be at the EMS agency. We'll let you know if that changes, and that brings us to adjournment. Yes, Steve, you have one more thing?
Steve Brooks, EMS agency staff, would like to do a roll call of those committee members that I have as marked present. If I missed your name, please let me know that you are in attendance. So those in attendance, Cassie Caldera, William Hiller, David Craddock, Nicholas Greenson, Michelle Kalinsky, Cole Click, Jeff Horner, Scott Houchin, Tina Nieto, Greta Steinbrunner, Christy Soboleski. If I've missed anyone, please do let me know. And we don't really have a good mechanism at this time that I'm aware of for those who are non-members to record attendance at this time, and I apologize.
Okay, thank you, Steve, and that'll bring us to adjournment. So I'd like to go ahead and adjourn, and thank you all for coming and participating.